Today I shall discuss on approach to congenital heart disease. Approach to congenital heart disease involves a structured clinical, diagnostic and management framework. So very shortly I'll discuss on these three titles. So to approach for a congenital heart disease, first you have to have a very earliest suspicion. You have to suspect this child is having congenital heart disease. So the earliest suspicion signs in case of neonate age group, that is birth till 28 days of life, these babies may have tachypnea, chest indrawing, cyanosis, that is turning blue, puffiness of the face. Baby may have difficulty in feeding, choking and then sweating of the head. So if you find these features, you have to suspect this baby might have congenital heart disease. Whereas in the older children beyond the neonatal period, they may present with failure to thrive. So this is not gaining, persistently not gaining weight. And child may have repeated chest infection. There is poor weight gain. There might be cyanosis, there might be clubbing, again dyspnea on exertion, orthopnea, that is difficulty in breathing. Child may have edema and then some may complain of chest pain, though chest pain is a rare manifestation in children. So if you find these clinical features, you have to suspect maybe this child is having congenital heart disease and then you have to further investigate this child. Now come to NADA's criteria. This is a criteria at bedside which tells you or which makes you suspect this child may have congenital heart disease. So for this there are major criteria 4 and there are 5 minor criteria. So out of this, presence of one major criteria or presence of 2 minor criteria, you have to suspect congenital heart disease and you have to further investigate. So the major criteria are systolic murmur grade more than 3, that is systolic murmur with thrill. Number 2, if the child is having diastolic murmur, it is always pathological. Number 3, cyanosis, and number 4, congestive cardiac failure. So features of heart failure if the child is having, you have to suspect heart disease. Minor criteria are number 1, systolic murmur less than grade 3. So without thrill, if there is a systolic murmur, this may be just normal. And abnormal second heart sound, abnormal ECG, abnormal X-ray, abnormal blood pressure. If the child is having 2 of the minor criteria, then you have to suspect this child may have congenital heart disease. So these are the clinical features at bedside which can tell you, which can lead you to suspect congenital heart disease. So this is given by NADA, so known as NADA's criteria. Now come to classification of congenital heart disease in short. So in detail I'll again tell you later. So here grossly the congenital heart disease can be a cyanotic, that is without cyanosis, and another can be with cyanotic, known as congenital cyanotic heart disease. So a cyanotic heart disease, number 1, occurs with a left to right shunt. So under this the disease coming under this left to right shunt is atrial septal defect, ventricular septal defect, patent ductus arteriosus and atrioventricular canal defect. And then obstructive lesions, that is including the tubes, comes under this. So pulmonary stenosis, aortic stenosis, coarctation of aorta is coming under the obstructive lesions. So all these are both are a cyanotic heart disease. And another broad category is congenital cyanotic heart disease. Here there is right to left shunt, deoxygenated blood is getting mixed with the oxygenated blood, so the child is turning blue in all these conditions. So this is, you can remember by the mnemonics 5 T's: tetralogy of Fallot, transposition of great arteries, truncus arteriosus, total anomalous pulmonary venous return, tricuspid atresia and hypoplastic left heart syndrome. So all these are, so for you for easiness you can just remember 3 holes, that means left to right shunt. So hole occurring in ASD, VSD, PDA. 3 tubes you can remember, so that is the obstructive lesions. So tubes are pulmonary stenosis, aortic stenosis, coarctation of aorta. Then you can remember 5 blue babies or 3 blue babies. So under this, or just remember 5 T's. So that way also you can remember, or 3 holes, 3 tubes, and then 3 blue babies. That way also you can remember the classification of the heart disease. So all these diseases I'll discuss individually, so where I'll be talking in detail. Now come to classification of congenital heart disease in short. So in detail I'll again tell you later. So here grossly the congenital heart disease can be acyanotic, that is without cyanosis, and another can be with cyanotic, known as congenital cyanotic heart disease. So acyanotic heart disease, number 1, occurs with a left to right shunt. So under this the disease coming under this left to right shunt is atrial septal defect, ventricular septal defect, patent ductus arteriosus, and atrioventricular canal defect. And then obstructive lesions, that is including the tubes, comes under this. So pulmonary stenosis, aortic stenosis, coarctation of aorta is coming under the obstructive lesions. So all these are both are acyanotic heart disease. And another broad category is congenital cyanotic heart disease. Here there is right to left shunt, deoxygenated blood is getting mixed with the oxygenated blood, so the child is turning blue in all these conditions. So this is, you can remember by the mnemonics 5 T's: tetralogy of Fallot, transposition of great arteries, truncus arteriosus, total anomalous pulmonary venous return, tricuspid atresia, and hypoplastic left heart syndrome. So all these are, so for you, for easiness you can just remember 3 holes, that means left to right shunt. So hole occurring in ASD, VSD, PDA. 3 tubes you can remember, so that is the obstructive lesions. So tubes are pulmonary stenosis, aortic stenosis, coarctation of aorta. Then you can remember 5 blue babies or 3 blue babies. So under this, or just remember 5 T's. So that way also you can remember, or 3 holes, 3 tubes, and then 3 blue babies. That way also you can remember the classification of the heart disease. So all these diseases I'll discuss individually, so where I'll be talking in detail. Now let's see the characteristic features, the in gross general clinical features of this acyanotic and cyanotic heart disease. So characteristic of patients with left to right shunt, this means these are acyanotic congenital heart disease. So under this ASD, VSD, PDA comes. This is ventricular septal defect, ASD is atrial septal defect, and PDA is patent ductus arteriosus. So in these children having these 3 types of congenital heart disease, the general clinical features will be, there is absence of cyanosis. Since this is a cyanotic heart disease, there is no cyanosis. These children, they suffer from frequent chest infections. They get repeatedly admitted with pneumonias. So this occur due to decreased lung compliance because of the heart disease. And that these children have high tendency to have congestive heart failure. So they have all clinical features of heart failure, and very prominent feature is excessive sweating. And another feature is failing to thrive, not gaining weight. So failing to thrive is due to poor oxygen saturation in the growing tissues. It may be due to persistent heart failure, the child is unable to gain weight. Frequent respiratory infection also discourages the weight gain, and then undernutrition because of the poor nutrition as the child is unwell. And in the clinical chest finding, you get precordial bulge due to frequent respiratory tract infection and cardiomegaly. And on auscultation, you'll get the shunt and flow murmurs. So in detail regarding the murmurs, I'll discuss when I discuss the disease individually. Now come to the characteristic feature of patients with who's having obstructive lesions. So in the obstructive lesion also a child is acyanotic. So there is absence of cyanosis and there is absence of frequent chest infection. Like in the left to right shunt there was frequent chest infection, but these children will not have any frequent chest infections. The precordial shape is normal and there is no significant cardiomegaly. So there is no precordial bulge like the left to right shunting. And some children may have chest pain, especially if they are having the aortic stenosis, which lead to myocardial ischemia. So obstructive lesion is occurring in the 3 tubes. So tubes means pulmonary artery, an aortic vessel, and also aortic coarctation of aorta. So these are 3 problems occurring in the tubes. So in the aortic stenosis, the child may have a chest pain. Other features will be when you examine forcible heaving cardiac impulse you may get in the precordium. There is ejection systolic murmur with thrill, and there is absence of diastolic murmurs. So in detail I'll discuss when I discuss the disease individually. Now come to clinical features in general in children who's having right to left shunt. This means deoxygenated blood is getting mixed with the oxygenated blood. So these children are cyanotic. So this is known as cyanotic heart disease also. So here the child is cyanosed, there is cyanosis, there is clubbing, there is history of squatting, there is polycythemia, and then you get cardiac murmurs. These children also fail to thrive because of the decreased oxygen saturation, because deoxygenated blood is getting mixed in the system, and then they may be associated with the syndromes. So all the types of congenital heart disease may be associated with the syndromes. So another typical finding is hypercyanotic spell, also known as TET spell. So this you get specifically in the Fallott's tetralogy and also in all the other cyanotic heart disease who follow the Fallott's physiology. So Fallott's physiology is followed in the conditions where there is pulmonary or infundibular stenosis. Because of the decreased pulmonary blood flow, they follow the same physiology. So the diseases coming under the Fallott's physiology will be all these 5 diseases, because there is a presence of large VSD with the pulmonary stenosis. So defects which follow the Fallott's physiology is complete TGA. This is transposition of great arteries with VSD, ventricular septal defect, and pulmonary stenosis. Number 2, corrected TGA with the VSD and again pulmonary stenosis. Number 3, double outlet right ventricle with the pulmonary stenosis and a large VSD. Number 4, tricuspid atresia with a diminished pulmonary flow, that is pulmonary with the pulmonary stenosis. And number 5, single ventricle with the pulmonary stenosis. So in all these conditions they follow Fallott's physiology. So bedside you get same clinical features. And in diseases where there is which is following the Fallott's physiology, the heart failure is very, very uncommon. It's not a common finding. But under this following condition, if the Fallott's physiology diseases have the following conditions, then they may go into heart failure. So those conditions are severe anemia, valvular regurgitation, infective endocarditis, systemic hypertension, coincidental myocardial diseases like a myocarditis, and if there is a cyanotic or pink tetralogy of Fallot. So if it is there, then they may have heart failure. Otherwise heart failure is a rare finding in diseases where which is following the Fallott's physiology. Now to approach for the congenital heart disease, first you have to take a very good history. So in the history you have to take an antenatal record of the mother, because if the mother is having these problems or if the mother is exposed to these things, then there is a high chance baby will be born with the heart disease. So those are maternal, rubella, and any other torch infections. So torch infection, T stands for toxoplasmosis, O is other diseases, R is rubella, C is cytomegalovirus, H is herpes simplex. So in these infections there is a high chance a baby might have congenital heart disease. If the mother has diabetes during the pregnancy, certain medications, steroidogenic drugs, if the mother takes, then high chance of baby having congenital heart disease. If there is a consanguineous marriage, then there are high chance of autosomal recessive disorders to occur in a child. So where again congenital heart disease is commonly associated with those syndromes. And if the mother is exposed to alcohol, or if the mother is smoking, so in all these conditions, so you have to take a good history in the antenatal history regarding the mother. Then you come to the postnatal history, where you have to take the history of frequent lower respiratory tract infection, that is for the acyanotic heart diseases with the 3 holes. There is a very frequent respiratory tract infections. And then if the child is having any history of cyanotic spells or squatting, very commonly seen in congenital cyanotic heart disease. History of syncope seen in aortic stenosis, pulmonary stenosis, or persistence of pulmonary hypertension. And if there is effort tolerance or orthopnea, you have to see this, because if the child is having heart failure, this clinical feature is very common. Then you have to assess the growth and development of a child, because you need to check whether the child there is a associated syndromes. So if there is syndromes, you even get the facial dysmorphism, so you have to check for all those also. And take in the history if the baby was large for date baby, because transposition of great arteries is associated with the large for date babies. Then you go to general examination. So in the general examination, important points will be, you check for the general health status of the child. Anthropometric measurements are important, as the child is failing to thrive. You take a good nutritional history to find out whether the failing to thrive is due to nutritional defect or due to cardiac defect. So it's very important to take a nutrition status also. You check for the dysmorphic features in a child. So head to toe examination is very important. You check for the position of the patient, like squatting position you see in the tetralogy of Fallot, or any disease which is following the Fallot's physiology. And check the cyanosis clubbing to rule out the congenital cyanotic heart disease. Then you check the vitals are very important. So pulse rate, rhythm, whether it is regular or not, you have to see, or any arrhythmias are occurring or not. Then check for the blood pressure in all 4 limbs is important in a cardiac disease. Then temperature is important if it is associated with the infections. Respiratory rate, it is usually high if there is a respiratory infection, if the child is having heart failure. Pulse oximetry to check for oxygen saturation is important, because congenital cyanotic heart disease, the saturation of oxygen does not rise, maybe beyond 70%. So it's important to differentiate whether it is cyanotic or cyanotic heart disease. Then come to the precordium examination, that is the CVS examination proper. Here inspection, palpation, auscultation is important. So inspection, you do the you check for the precordial bulge. So many diseases they may have precordial bulge. Check for if there is any visible apex beat or any other pulsations or engorged vessels in the precordium. Then go to palpation, locate the apex beat and see the character of the apex, whether it is heaving, tapping, and then you check for the thrills and parasternal heave. And then go to auscultation and check for the heart sounds, first heart sound, second heart sound. Second heart sound is important. So here you have to see whether there is a single second heart sound or there is a splitting characters are important. Then check for the cardiac murmurs, what type of murmur it is, systolic, diastolic or continuous murmur. Check for the pericardial rub. So regarding the detail about all these findings, further details we'll talk when we are discussing the individual disease. So in general, you need to examine these things in the precordium. Then other relevant examinations are hepatomegaly. If there is a heart failure, you get a hepatomegaly. Then check for the peripheral pulses. Radiofemoral delay is important. If there is a coarctation of aorta, there is a radiofemoral delay. And then check for signs of heart failure like hepatomegaly, edema. So all these are, and then basal crepitations can be found. And then jugular venous pulsation is also important to check for the heart failure. So in general, these are important examination findings. Then when you approach, you have to do investigations. So the screening investigations are X-ray, ECG and echo. So these 3 are important. X-ray to look for cardiomegaly or check for the pulmonary vascular markings, whether there is a plethoric lung field or oligemic lung field, high or low vascular markings you have to check. But in which disease it is occurring we'll discuss when we are discussing the diseases. Then look for the lung infiltrates for any pneumonia or any lung infections, which is very commonly seen in the cyanotic heart diseases. Then ECG, you check for the chamber hypertrophy and axis deviation. Then you do the echocardiography or Doppler echo for the final diagnosis, where you can detect the structural defects of the different heart diseases. Then other investigations is hyperoxia test. So this is to differentiate whether the cause of cyanosis is from due to pulmonary cause or due to cardiac cause. Bedside, this is one of the bedside tests to differentiate whether the cyanosis is from due to pulmonary cause or cardiac cause. So if it is due to cardiac cause, the saturation will not increase in spite of giving oxygen, but if it is a pulmonary cause, when you give oxygen the saturation improves. So this is hyperoxia test. Then you can do cardiac MRI or CT. These are done only if there is a complex, if it is a complex cases and you need to see detail regarding the vascular anatomy. Then cardiac catheterization, angiography are other investigations which are usually done in the complex congenital heart diseases, and usually it is a preoperative planning. And then complete blood count, just to see polycythemia or if there is infection, so to detect all those things, just as a screening, or whether anemia is associated. To check all these things you can do just a complete blood count, where you see the RBC, WBC count, and then differentials you can see, and also hemoglobin. Now come to management. So management approach will be, first is medical management followed by surgical. So in the medical management, give oxygen if required. If there is a heart failure, use diuretics, ACE inhibitors and inotropes. If there are pulmonary infections, use antibiotics. And ductus dependent lesions, just to keep the ductus open, you need to use prostaglandin E1 infusion. And many times you need to close the patent ductus arteriosus, so where you use the indomethacin. So these are few medical management you can use. In detail regarding these medications we will discuss later. Then they require finally surgical interventions. So in this interventional cardiology is there, so where very minimal invasion is required. This is very minimally invasive procedures which is performed by the cardiologists, not the surgeons. So here usually the cardiologists, they use catheters which is inserted through the blood vessels. Usually they use the femoral artery or vein, and this is done in the cardiac catheterization lab, not in the operation theater or operation room. So some example of the interventional cardiology is balloon atrial septostomy, balloon valvuloplasty also you can do. You can do some device closure for atrial septal defect, ventricular septal defect or PDA, and then sometimes you put the stent. So all these can be done in the interventional cardiology. And then finally comes the surgical cardiology or surgery. So surgery, there are two types. One is palliative surgery, another is corrective surgery. Palliative surgery, these are done just to relieve symptoms and stabilize the child or patient, and this is done where the full correction is not immediately possible. So just putting shunts, all these things they do, but they do not correct the structure because the child is not yet ready, or the full correction is not immediately possible because child's condition is sometimes not good, sometimes weight is not good, sometimes the hemoglobin is too low. So for those you delay the total corrective surgery. So that time you just do the palliative surgery to relieve the symptoms and then just to stabilize patient and then give them a better life. Then later you plan the corrective surgery or definite surgery. So both can be open heart surgery. So finally you correct the structural defects, or you can just do all the corrections which are occurring in the structural heart defects. Okay, thank you. So this was the approach to a child who's having a congenital heart disease. Detail regarding the disease we'll discuss later individually in different classes. So if you find my class helpful, please subscribe, like and share. Thank you.